Good afternoon. My name is Lane Wells, and today I'll be presenting on difficult airway management in the ICU. As a respiratory therapist working in critical care, airway management is something we encounter regularly, but in the ICU, it's something that we take very serious and it's pretty straightforward. The patients in the ICU mostly are unstable, hypoxic, sometimes fragile. Um, this presentation focuses on identifying difficult airways, preparing appropriately with equipment, teams, and applying evidence-based strategies to improve patient outcomes. Learning objectives. By the end of this presentation, participants will be able to identify predictors of difficult airway in ICU patients, differentiate first line and rescue strategies, develop a stepwise airway management plan, and apply evidence-based recommendations to a clinical case scenario. These objectives are measurable and directly applicable to bedside ICU practice. Why this matters in the ICU? Well, ICU intubations carry significantly higher complication rates compared to OR environments. Critically ill patients often present with hypoxemia, metabolic acidosis, shock. Because of this, even brief apnea can even lead to a rapid deterioration. De Jong and colleagues in 2025 emphasized that failed first pass intubation increases complications significantly. In my clinical experience, I've seen in the past 22 years, once saturation drops below the 60s, the scene becomes chaotic. People start panicking, but having a prepared mindset, having the equipment steadily, and everybody knows their job, and their first pass success are critical to patient outcomes. Predictors of difficult airway. Structured airway assessment improves outcomes. The MOCA score is validated specifically for ICU populations and helps predict difficult intubations. Factors include Malaparti 3 or 4, obstructive sleep apnea, limited cervical mobility, restricted mouth opening, coma, and hypoxemia. Leaquad et al. 2025 reinforced the importance of using structured assessment tools in critically ill patients. As respiratory therapists, we often recognize these warning signs early. It's our responsibility to communicate concerns before intubation occurs. We see the patients, we're monitoring the airway oxygenation status and everything, and it is our responsibility to communicate those to the anesthesiologists, doctors, and nursing as well. Airway assessment. The limit approach provides a structured way to evaluate the airway. Look internally, evaluate the 332 rule, Malaparti classification. You can also look and see if there's any kind of obstruction. What is the patient's neck mobility? Was there some sort of trauma to their neck? Are they were they from a car accident or anything like that? Do you have to use a device to intubate? In addition to the anatomy, equipment preparation and backup planning must occur before sedation. Clear team communication to intubation reduces errors and improves coordination. The team approach is always the best. Communication, knowing about the patient, what can happen, having everybody readily available, regardless of the situation, but expected emergency situations and being prepared for those can help improve outcomes. Pre-oxygenation strategies. Pre-oxygenation is one of the most critical steps in preventing intubation, hypoxemia. High flow nasal cannula can provide apneic oxygenation, non invasive ventilation improves oxygenation in patients with severe hypoxemia. Head elevated positioning improves functional residual capacity. Um, Risotto et al. 2024 demonstrated improved oxygenation outcomes with non-invasive ventilation during emergency intubation. Those are patients on BiPAP. A lot of times during intubation, you notice the doctors keep the patient on the BiPAP at 100% until they're ready to look into the airway. Those help improve outcomes. In patients with ARDS or COPD, skipping proper oxygenation significantly increases risk of desaturation and or even cardiac arrest. First line strategy. Video laryngoscopy is now preferred in critically ill patients due to improved glottic visualization and higher first pass success rates. Rapid sequence intubation remains standard practice. However, hemodynamic optimization must occur before intubation. Vasopressors should be prepared and readily available in unstable patients. De Jong et al. 2025 emphasized that first pass success is associated with fewer complications and improved patient outcomes. That means having everything readily available, medications, equipment, staff, all necessary intubation equipment should be readily available, regardless of you foresee needing it or not. Rescue strategies. Every airway must have a backup plan. Rescue options include bougie assisted intubation, supraglottic airway devices, and emergency surgical airway when necessary. The Massey 2025 highlights the importance of activating a difficult airway algorithm early rather than after multiple failed attempts. Hope is not the strategy in airway management. Structured escalation saves lives. Having everything readily available, like we said before, rather you're going to need it or not. Oftentimes, I've seen difficult or even simple airway intubations fail because equipment wasn't readily available. The simplest things help even improve even complicated situations. Complications of intubation. Common complications during ICU intubation include severe hypoxemia, peri-intubation hypotension, cardiac arrest, and aspiration. In many cases, physiological collapse occurs before technical failure. Critically ill patients cannot tolerate prolonged apnea or delayed oxygenation. Anticipation, preparation, and minimizing attempts are keys to reducing these complications. Interprofessional roles. Difficult airway management is a team event. The respiratory therapist's job manages oxygenation strategy, equipment preparation, and ventilator setup. The physician or advanced practice provider performs the intubation, and the nurse administers sedation, monitors vital sign, and manages IV access. The pharmacist assists with medication preparation and dosing. Effective teamwork improves safety and aligns with interprofessional collaboration principles emphasized in this program. This is the team approach, having everybody there will help improve outcomes. The most basic intubation on the floor, pharmacies there, there's multiple nurses there documenting and administering meds, doctors there, maybe even 2 respiratory therapists to assist with maintaining the airway. Case scenario. This case involves a 68-year-old male with COPD and pneumonia. His saturation is 82% on a non-rebreather mask, and his blood pressure is 86 over 52. Before intubation, make sure vasopressors are prepared. I would initiate non-invasive ventilation for pre-oxygenation. If the patient can tolerate it. The patient should be positioned head elevated. Video laryngoscopy would be my first attempt with a bougie readily available as a backup. This structured stepwise approach reduces complications and improves first pass success rates. Best practice recommendations. Best practices include using structured airway assessment tools, preferring video laryngoscopy, preparing vasopressors prior to intubation. Um, Also, Risotto et al. 2025 and De Jong et al. 2025 emphasize system-based approaches to airway safety rather than relying on individual skill. Also implementing ICU airway checklists. ICUs, the floors that I work at, they do have difficult airway that is present during every intubation, no matter how simple or how complicated it can be. Those difficult airway carts and airway teams are always present during um, any intubation. If it's emergency, they get the team there, and we may start, but everybody is on their way to the intubation. Leadership and quality improvement. Beyond bedside management, leadership and system improvement play a major role in airway safety. Standardizing ICU airway carts reduces delays and variability. Simulation training improves team coordination and crisis management. Tracking first pass success rates allows departments to identify opportunities for improvement. As a respiratory therapist leader, I believe airway management should be treated as a performance metric and continuously evaluated for quality improvement. Like we have many like mock codes and mock emergency situations. Our department or hospital leadership is working on doing these has intubations and checking to make sure everybody's doing their job, noticing first pass success rate and how that helps the patient with their outcome. Conclusion. Difficult airway management in the ICU requires preparation, anticipation, and teamwork. First pass success significantly reduces complications. Airway management is not just a procedure, it is a system involving assessment, planning, and coordination. That is the end of the presentation. These are my references that I use for the presentation.